Welcome to the Essential Substance Abuse Skills webinar series. I'm Kate Trams, and today we've invited Ed Haycraft and Brenda Hill to speak on counseling families, partners, and significant others. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network shown on this slide. The network also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. We recommend that if you are preparing for an exam that you seek additional preparatory help and let this course be one of many tools you use to prepare. Our next webinar in this series is scheduled for Wednesday, October 15, when Drs. Dolores Bigfoot and Anthony Stately will present Professional and Ethical Responsibilities. We also offer the American Indian and Alaska Native Behavioral Health webinar series, and will welcome Ray Daw on October 1st to present Nutrition and Behavioral Health. For more information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEHs for a $15 fee. The CEH request form is available for download in the Files pod in the webinar screen, and I will also be sending this form out in a follow-up email to all who attended. Immediately following today's webinar, you'll be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. If you've never used the Adobe Connect system before, you may view the presentation in full screen mode by clicking on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing outward. To return to the regular view, click the button again. You will be muted for the duration of this webinar. Please use the Q&A pod to share your questions and comments, and we will address questions at appropriate points during the presentation. And I just wanted to note there, we will actually have 2 sections to this presentation. Ed Haycraft will be presenting first, and so we'll have a question and answer session at the end of his section, and then we will also have one at the end of Brenda Hill's section. And we'd love to welcome you to submit your questions at any time so that we're kind of ready to go at that question and answer time, and we can address those right away. We'd like you to also be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today we have Ed Haycraft joining us to present on counseling families, partners, and significant others. Ed is currently working for the Department of Veteran Affairs as a clinical social worker and is adjunct faculty with the University of Iowa School of Social Work. He's been practicing in the field of chemical dependency since 1999 in a wide variety of settings. We also have Brenda Hill joining us to speak on advocate perspective, victimization, and substance abuse. Brenda is the Native Co-Director for the South Dakota Coalition Ending Domestic Violence and Sexual Violence. She has worked in the field of domestic violence and chemical dependency and shares her expertise with us from her experience as an advocate and also as a survivor. Thank you both so much for being with us today, and I will pass things over to Ed at this point to get us started.
Thank you. Good afternoon, everyone, and I'd like to welcome you here today, and please feel free to submit any questions as we go along, and I'll answer them to the best of my ability. I would first like to just go over this page right here quickly, kind of some goals and objectives. So we're going to talk a little bit about the characteristics and dynamics of families and couples and significant others and how they're affected by substance use. Become familiar and with some of the models of diagnosis and intervention for families, couples, and significant others, including extended kinships or tribal family structures. assist families, couples, and significant others to understand the interaction between family systems and substance use behaviors, and assist families, couples, and significant others to adopt strategies and behaviors that sustain recovery and maintain healthy relationships. So people say, why family therapy? Because many times I think when we get working with individuals, we really focus on the individual themselves, and sometimes not the entire family. And I think it's really important to look at the strengths that are present within the family structure itself. Because as I like to tell people, and I come from a real motivational interviewing type of a background, and I like to look at the individual as the expert on themselves. It's certainly not me, it's the individual. And when you're looking at the family really has a tremendous amount of knowledge on the issues within the family and the familial structure itself. So looking at the family strengths and helping identify the strengths is extremely important when working with families. And also building that family support network and looking at how each other interacts can be very powerful when providing therapy to an individual. Some concepts of family therapy, and especially if you look at family systems therapy, the system is more than the sum of its parts, a very Gestalt-oriented type of philosophy. And the systems of the family are interconnected. And there's rules that determine the function of the family system and how the family dynamic balances itself. And so, there's always this systems approach towards looking at families and the way that they're interacting. And I like to do many times to actually do a systems map. And if you haven't seen a systems map, it's a stratified type of a circular map with the family in the middle of that map, and then the interrelated parts as they stratify out from the family, and how those other outside entities even function with the family and interact with the family. But when you're defining those different systems within the family itself, and you do a systems map with the family, you can look at the connections between each family member and how those relationships are either positive or negative, or who's receiving the benefit of the relationship, and how they function back and forth with each other. Many times when you see families that are also in stress or dysfunctional, or just have a tremendous amount of stressors within the family, they become very static, so they don't allow any outside many times outside input into the family. They become very closed off, and you can identify where those issues are happening within the family as well when you look at it from a systems perspective and actually look at the family networking within itself. So individual therapy can really focus on the person. So again, back to what I said a few minutes ago. So when you're doing the individual therapy with the person, you can look at their strengths. You can focus on the individual, help them self-actualize, and really identify problems that they feel are important to them, and also then identifying their strengths as well. But family therapy kind of takes it out one more step. And again, I think it's extremely important to look at the family and to identify the family. And at this point, it's also, I think, important to identify your patient or your client, what is family to them, and to sit down and maybe doing some type of a family map. Because many times it's going to be the family of origin, or the family, the biological family, or the STEM family as we call it. So many times it's just the husband or wife or partner or whatever the case may be, and then any offspring. And as you start to look at this process, it also might be more of a kinship type of a structure, where you have individuals that people consider to be family that might not be part of that immediate family as you might perceive it. So it's really important, I think, to look at to the patient and help them identify what is family to them when you're going to start to look at different family therapy models and maybe doing a type of family intervention. Cultural considerations are extremely important. And we'll talk about the Native American culture here just a little bit. And in understanding that within any diverse population that you might happen to be working with, that there might be different definitions of family and the way that family members interact, whether they're a maternal or paternal type of a structure. So which is placed in the hierarchical structure as being, like the direction that people perceive of being the real strength of the family. Excuse me. And also understanding that I think we all come in with perceived notions about other cultures or other ethnic backgrounds, and to be very aware and attentive to your own thoughts, but yet to be very open to exploring with the person sitting in front of you or the family sitting in front of you, how they perceive their own issues in the context of their culture. Um, so with the way that our society has continued to evolve, I think it's important to understand that many times when you walk into a treatment facility as an employee, or you're providing services as an employee, that you're going to meet a very diverse population many times, especially depending on where you are geographically as well. So obviously in some areas of the country tend to be a little bit maybe more diverse than others. And here again, as this says, is our own worldview healthy? Understanding and addressing your own possible prejudice or predetermined thought processes about a given culture or a given ethnicity. And to also understand that differences aren't necessarily problematically. Actually, they can be quite healthy when you as a clinician feel healthy about your own perception and your own view, and always be willing to learn. I think myself, I've always walked in with a concept of help me understand, and be open to asking. If you don't understand something, ask the individual, and it shows that you're willing to learn and you're not always playing the role of the expert. At the same time, as the next bullet point suggests, if you overemphasize the difference, it can many times distract from the counseling itself. So understand that everybody has I guess concerns. Everybody has differences, and not necessarily segregating the client out because of their differences, but invite them into the counseling conversation and explore that with them. I think is a very important attitude to have towards working with people of diverse populations. This is the Native American family based on Dakota, Lakota, and Nakota traditions. And I think everybody, just take a quick look at this. I'm not going to spend much time talking about this. It is available in the SAMHSA tip on Native American populations, which I would suggest getting a copy of, especially if you're working with Native Americans and Alaskan Natives. What I like to point out when looking at familial structure within tribes, I just go back to an individual that I've worked with, had worked with for quite a period of time from the Fox tribe here at the Meskwaki Indian tribe close to Iowa City here. And the way that their family structure was, and just the differences in I guess importance they place on other members of the family. It can be somebody that to us would maybe be a distant relative, and to them like a cousin third removed. It's not going to have that same same I guess importance maybe to us as it might just to someone that's actually living on a tribe, and their family is very tightly, bound to each other, and so that person holds a different spot in maybe their familial structure than what it might ours. And I think it's just really important to be aware of that, and the uh, impact that they might happen to have, as well as tribal council, because I know this individual struggled a lot with his addiction, and how he felt that the tribe would view him, and also view, how he would be viewed by tribal council. So it's another factor that you need to take in place when you're working with individuals, especially if they're living on a reservation, and the impact that the tribal council has on the individual as well, if things are brought to their attention, as far as the way that they may communicate. Um, these are the 7 values, and this is a very holistic type of a thought process here, or just, I guess, cultural process and cultural viewpoint. Um, and what they hold to be extremely important, with the humility, wisdom, praying, respect, caring, compassion, generosity, and helping. So I think that this is a very important thing to look at when working with individuals. So stages of family change. So when you're looking at stages of family change, and I guess the importance of the concepts here. So the attainment of sobriety. Um, First of all, to attain sobriety, what can the family do to help and support the individual to attain sobriety? How do they work together? What can the family do? What information can you gather from the factor about the support of the structure of the family, and how that relates to the individual? And then the adjustment to sobriety. And I think when you're looking at families, the adjustment to sobriety is one of the most important factors to take into consideration. Um, and I'm actually working with a veteran right now, and the individual has attained sobriety, but the direction that the individual has gone since he has attained sobriety is not necessarily what the family expected. So the family is having a very difficult time adjusting to that change, especially if the families has maybe been caregivers to this individual. And we'll talk more a little bit about codependency a little bit down the road here. But when that family structure changes because the individual has now become sober, it can be just as shocking or crisis provoking to the family as the individual's use, because it creates a rapid change in the family structure and what the family has been providing for each other. And many times people feel lost. They don't know because the person here again might not go in the direction with their sobriety, as far as responsibilities, as far as just maybe even relocation, because the veteran I'm working with has actually decided to relocate, and it's been a complete shock to his family, and they don't know how to cope with that. They felt that he would come back and be part of the family here within the area, but he's decided not to do that. He's wanting to have a complete change, to kind of start over freshly, and it's been a significant shock to the family. So people do things that and then they come back and say, well, did the therapy do this? Is this what it's like? No, this is what the individual decided to do themselves. So here again, I think the adjustment to sobriety can be very shocking to the family. Also looking at the family and how to set up long-term maintenance of sobriety and maintenance of change. So there's significant change that takes place. The family many times struggles to adapt, and looking at that and addressing that within family counseling sessions is very important. And how's that family structure going to look? As I was just talking about codependence, dysfunctional families, enabling, I have always looked at the codependency as the dependency of the enabling individual on the identified patient. So their actual dependency on that person. So that's what kind of precipitates the dysfunctionality of the family, because they, many times they become the caregiver. They do things. One thing that I see, especially working many times with older individuals, well, with anybody, quite frankly, but I've seen it in a lot of elderly people with real chronic substance use issues. People will bring the alcohol or the substance into the home, and then they go, well, you've got to do something to fix old Bill. Well, where's the alcohol coming from? Bill can't even drive. Well, we bring it to him because he becomes extremely upset and violent if we don't bring him alcohol. So helping the family understand that and the concepts of codependency and just how they enable that person. And that really is looking at the dysfunctional portion of the family. Also looking at just issues of esteem and how the codependent is valuing their own esteem and actually their sense of efficacy as well. So not just esteem issues, but sense of efficacy. So the sense of change. So are they able to impact change on themselves? How about the individual? Are they able to impact, change themselves? How do they feel about that? How do they feel that the family can help them? And how does the family feel about helping them? One of the things that we do, especially when in one of the interventions that I've been involved in, which is the matrix model, actually has a worksheet on what am I going to allow my family member to do. So and then also what is the family member going to allow of the individual to ask of them. So what am I going to feel comfortable about allowing this person to ask of me or ask for support? How is that structure going to look? And what do the family members feel comfortable with? So continued on family dynamics. So many times people continue to stay in relationships, and I'm sure that in the next segment here, she'll be talking more about domestic violence, but people stay in these relationships when they're very abusive and they're not being treated well. Many times it has to do with that sense of self-esteem, that sense of self-efficacy. They continue to stay with individuals when it's not maybe positive for themselves or for the individual for them to stay in that relationship. And as it says here, feelings less able to or powerless to influence the family dynamic. So the person feels that sense of efficacy. That's what I'm talking about, that sense of being able to influence the family dynamic. And how's that going to look? And trying to explore that and build those structures back up in the family when you're doing family therapy with the individuals. So we're going to look at some of the different structures within the family. So if you've got client lives with partner and minor children, so many times the effect on the child can be profound. Many times there's maltreatment going on, there's abuse, there's neglect, and many times children internalize that and see that as being their own problem, their own fault. They feel guilty for the responsibility of the substance using parent. And they'll hold this, and like I said, they will internalize it, and it can be very detrimental to the child's development. And there are issues with trust, as it says, trust and intimacy, especially if there's abuse, physical abuse going on within the family unit itself. You're going to see many times a risk for mood and anxiety disorders. I also talk about post-traumatic stress disorder when looking at this, because many times children are subject to post-traumatic stress disorder, and that's actually what's going on, especially if you have a very violent individual in the household. And not even just physically violent, but verbally abusive. If the parent's going on a tirade or going on an extreme emotional outburst, it can terrify young children, and they can end up becoming end up with a diagnosis of post-traumatic stress disorder. And I think it's extremely important to identify that within the familial structure if you're treating the children as well. You'll see higher rates of divorce, violence, and that the whole power and control, and the way that the power and control in the relationship just develops within the individual that is having the substance use issues. And as the bottom bullet point says, amazingly, some children are very resilient and adaptable. You'll see some kids that really pop out of this and do quite well, while at the same time, other children just are not that resilient. With adolescents, and you'll see, and I think what you see many times, and because I've actually been an adolescent counselor for a while as well, you'll many times see the adolescents mirroring the behavior of the parent. So if you have a high risk parent, many times you end up with a high risk adolescent, and you'll see that that repeating cycle within the family. And I think what's really important to identify is that many times adolescents just don't have the decision making and the coping strategies and coping skills developed that are necessary to deal with this. And also we know that if you're looking at the impact on neurological development and within the rational decision making process, that occurs younger for young females than it does young males. And so you're looking at high risk substance use within a period of time within the individual when their brain is not fully developed yet and they're unable to actually make rational decisions. And that can last into adulthood if the substance use issues are not addressed. So some of the different structures that we look at here: client lives with a partner, client lives with a partner and minor children. Client is part of a blended family, which that can have issues too, depending on how the parts of the blended family interact. Another time when it's very important to do some type of a structural family map. Older client with adult children, and adolescent client and family of origin. Excuse me. I just talked a little bit about the older client with adult children and how that might look if there's the older individual that is the one who's chemically dependent. So counselor involvement. So sometimes there's minimal family involvement, and it kind of depends on how the counselor's been trained and also where you're working and what has been maybe the focus of therapy. I always suggest that when you're looking at cultural issues and when you're looking at family therapy, it's very important to have other training on this, attend other seminars and lectures, because there's many different models out there. There's Bowenian family therapy, there's structural and strategic family therapy, there's narrative therapy, solution-focused therapy. So it's really important to have an understanding of how those different therapies work. You may just be providing a low-level advice, so maybe just some information and advice. So looking at what's important to the family, providing advice to the family. Other things, you might be stepping it up another notch and looking at feelings and support, within the family structure and how that works to the family as well. And then you also might be providing some other type of grief-focused intervention, which like strategic family therapy or solution-focused therapy would provide for the individual. So the 7 C's, that what we call this next slide, excuse me again. So I'll cover these on the slides individually as we walk through this. So character features. So what are the characteristics of the individual that are very identifiable and might precipitate some of the issues? And also, these can be used in identifying strengths within the individual as well. So what are some of the strengths within the family or within the individual, and the characteristics that are present, as it says, a major role in defining that person. From a sociological perspective, we would look at that as what is maybe the master status of the individual. So where do they work? What is their profession? What are some of those things that you can identify? And also, where are they in the family? Where do they identify themselves as being in the family unit? When you're looking out, and this is very identifiable if you do like a systems map of the family, what are the cultural and ethnic factors outside of the family that help focus and shape relationships? This is extremely important. As I was working with the Native American population, it's very important to look at the cultural and ethnic factors. Look at the external factors within the tribal community and how those influence the family and the decision-making process within the family, and maybe have also precipitated issues within the family. Like my gentleman that I worked with, he was very, very, very paranoid about having the tribe actually know about what. I shouldn't say paranoid. He's just extremely concerned that he did not want any communication from the outside providers from the VA back to the tribe about any issues to deal with his substance use and substance use disorder, because he felt that would harm his position within the tribe. So I think these things are very important to look at. Contract features. So when you're sitting down with the family and you're coming up with ideas and solutions and how you're going to take and address that, and you're coming up with a treatment plan. These are types of things that, especially doing a treatment plan with a family, are very important. And I always say, think about your research, okay? Think about research. When you're defining research and you're looking at defining variables and causality, you kind of want this to look very much like that. So be very explicit, be very specific in defining goals and objectives and how that looks. Make sure that it's something that is attainable. So is this something that makes sense with the family? Does this make sense to the individual? Does it make sense to the family? Are these things mutually agreed upon? So working in a very partnership-oriented type of an environment is very important when you're doing this. And make sure that it's beneficial to everyone involved, so that it's not just a one-sided type of a contract or one-sided type of a plan that you're looking at within the family. So is there a commitment? So as it says, being involved with, remaining loyal to, and maintaining a relationship over time. So, not only does it make sense, but, does it add to the stability and the quality of the family? Is it something that makes sense? Are the people committed to this? Are they obligated to one another? Are they obligated to the family? And that also might be something that you have to work on, because sometimes those aren't where they want them to be. They certainly might not be where one person wants them to be. And when I talk about this within family structure, when I'm lecturing, I teach a marriage and family class. You many times see, if you have a scale and you're putting the members of the family on this scale, very seldom is that totally equal within the family members themselves, as far as power, as far as who's receiving the support from the family. It's nice to have things equalized out, but many times it's not, and you can see that scale tilting one way or another many times within the family. So I think it's important to take and have those discussions as well. So caring. So how do families express caring with one another? How does this happen within the familial unit? Is there intimacy taking place? Many times intimacy can be a very large problem within a family if that's not happening. And many times that can totally be affected by the substance use as well. So if somebody's more focused on their substance use than they are within their conduct to the other person in the family, it can completely destroy affection and sexual relationships, either because of an inability or just because of the focusing of that the person has put on their substance use, that it's taken the focus away from the family and away from the intimacy within the family unit itself. Are people doing things that are mutually pleasing with one another? And here again, I think this can be identified in doing a treatment plan with the family or coming up with some type of a behavioral contract within the family. What are some things that you're going to do together that you can find pleasure? What used to work? And I think here again, what used to work? Go back to maybe before the substance use was detrimental to the family. What are some things that you have done together that you have found mutually pleasurable? And identifying those things. Here again, it comes down to identifying strengths within the family. So that leads to the quality time. So if it's mutually pleasing, people are going to be having more quality time together. And this is also part of the recovery process that is very important, because it's important for people to substitute that using time or the time that they spent involved with their addiction into quality time doing other things. And if they're dedicating to the relationship, they're dedicating to the family, it can be something that can be used to replace that time that they spent using, and can be quite positive within the recovery process for the individual. And I think even identifying, as it says in the bottom bullet point, supportive and understanding friendship. So not only within the family, but even outside of that family. And you find this to be very important within kinships and kinship relationships. So what are things that we can do to be interactive with friends, to be interactive in the kinship, to be interactive with our family members that the addiction has taken from us? Open and honest communication is one of the most important things when looking at somebody with chemical dependency issues, because many times the substance use disorder has made the person maybe be less than a valid historian, and also made them maybe added to their ability to be honest with other members in the family or within the kinship. Many times people are just not being honest with themselves. So I think promoting open, positive daily communication with family members is of utmost importance, and also identifying that within a treatment plan. I think it's extremely valuable. I like this conflict resolution model here. I think it's important, and actually think about this yourself. How does this work maybe within your own relationships, or either just professionally or within your own family. So when you're good communication skills, conflict resolution. Many times people get so amped up that they don't slow down and stop to identify the problem. They think about that, and maybe how this um, uh, how that you work on conflict resolution yourself. I know that many times things just tend to build and build and build with conflict, and people become very headstrong and they don't slow down and stop and look at, and really identify the problem. Outline options. So sit down and actually go through, outline the options. What is available? What makes sense? What are the consequences of the options? So what would the manifest and latent functions be? So manifest meaning what are the intended functions of a possible option, and maybe what would the unintended functions of a possible option be? And then vote. Just don't make a unilateral decision. Vote. Does this, let's see if we really want to adopt this, and is everybody on board? Is there a consensus? And then evaluate that after the change has actually been, excuse me, after the change has been implemented. Is this something that is working for our family or not? So as a bit of a summary, I think it's important to build upon the strengths of the family. So this is very strengths-based focused, and I also would recommend looking at strengths-based therapy, and also looking at motivational interviewing skills to take and work on these issues with the family. It can be very powerful. And it can also look at using the family as their own source of expertise. They're the experts on their family unit, and you're sitting in the counseling position and helping them sort that out, and hopefully in a very directive manner, or guiding manner, and not necessarily a directive manner. So guiding them through the process instead of directing them through the process. And I think you'll find that you'll have a much better success if you're doing that. So really looking at the values of the family, looking at identifying the strengths to help them identify a healthier lifestyle, look at the emotional support and the balance within the family, the commitment to the family members, the communication style within the family, and maybe things that you can do to take and help support that. Look at the tradition and cultural issues, um, regardless of the culture, regardless of the ethnicity. Also, when working with same-sex couples, it's very important to look at the background and to maybe look at the kinship that they have established for themselves, because you might not have a biological family members in place because of the individual's decision to live as a same-sex couple. And look at the experiences that the family members have had, and kind of what they're expecting of each other, and what they're willing to do to be flexible within the decision-making process to move the family forward. Also identify any unhealthy communications within the family, and maybe referrals that you could do to help the family out, whether that be within maybe an anger management, a DVIP class, or domestic violence intervention program or class, and helping the family evaluate those other resources that might be open to them as well. So I'm going to take and stop right there and open this up if people have any questions for me to my portion of the presentation.
Yeah, thank you so much, Ed. And as he said at this time, if you have a question, please go ahead and type them into the Q&A pod. It's just to the right of the presentation pod. So if you've got your presentation on full screen, you'll want to click that full screen button again, and so you can see the question and answer pod and submit some questions. So I have a question for you, Ed. Actually, do you always have the practice of bringing families in when working with a client on substance abuse and recovery, or is there a kind of process by which you decide whether or not to bring the family in?
Usually there's a process. Generally speaking, if you have the family structure there that is being negatively impacted by the substance use, I think it's very important to bring the family in, because many times, again, you'll find that the client themselves may be dealing with issues of being honest with themselves, so they may be in contemplation, pre-contemplation, and when you bring the family in, you can maybe sort some of those things out. You don't always have the luxury of being able to bring the family in because of location, also because sometimes the family does not care to be involved, and sometimes the patient just will not allow it either. So I think it's always healthy to bring as many people in that's tightly related to the patient as possible, though. It helps provide more support. You can find more strengths within the structure, and that's going to help the person when looking at the overall lifestyle change.
Okay, great. It doesn't look like we have any other questions at this point, so I think we will go ahead and we do have just a comment on, I like the acronym for SOLVE. So yeah, thanks for that comment. And yeah, so if there are no more questions, I'll maybe just give another minute for people to submit any questions before we move on. So yeah, get those in right away if you're wanting to ask a question of Ed before we go on to the next section.
I just want to thank everybody for being online with us today. Thank you.
Yeah, thank you so much for joining us, and yeah, and thank you, Ed, and we just appreciate you bringing your experience and your perspective, and yeah, I think we'll doesn't look like we have any other questions, so we'll switch over to Brenda's presentation, and yeah, just thank you again, Ed, for being with us, and we yeah, look forward to the next time we have you with us. Okay, so now we will transition. So Brenda Hill is going to be speaking more to the advocacy side of working with domestic violence victims. And so Ed has been talking mostly about the role of a counselor working with clients, and Brenda is going to talk more about what it means to be an advocate of a victim. So yeah, we want to welcome Brenda, and thank you so much for being with us today.
Thanks very much. I really appreciate being asked to present this information, although it certainly is just the tip of the iceberg, so we'll be moving rather quickly. Certainly, alcohol and drugs are really interrelated with all forms of victimization, and there seems to be a lot of continuing I think, misunderstanding and confusion. But hopefully the two fields are starting to be able to do a little more collaboration because they do impact each other. But I think some of the main issues I'd like to bring up is that alcohol and most other drugs do not cause violence per se. I mean, if you're doing meth or something like that, you'll see more violence. But too often I've heard people say, well, if everyone gets sober, then, you know, the drastically decreased levels of violence. And that might not be the case, especially when we're talking about battering or rape or other forms of sexual violence. On the other hand, the results or the impact of sexual violence and battering in particular can cause substance abuse or dependence. So again, they're highly interrelated. If battering does exist, there is levels of violence already occurring, and you combine that with alcohol and other drugs, then what you will see for sure is more intense and frequent violence, more bodily injury, more criminal violence, often increased substance abuse, and then also increased relapse. Safety is a huge factor in people's ability to maintain sobriety and follow through with their recovery. One of the things I would like to clarify is that when we're talking about violence against women, is how I usually put it. Obviously, men are battered as well, but that they compose about 5% of those victims of battering. Often are also, victims of different forms of rape and sexual violence. But these are violent crimes. They obviously impact people's mental health and well-being as well. So not to exclude those, but it's about, again, perspective. If violent crime is occurring, then the response needs to be different than if we're purely dealing with a mental health issue. So substance abuse, from advocates' perspective, especially, it's important to make distinctions. Sometimes there's experimentation, but very often when victimization is involved, you're looking at a survival skill or tool, not a productive one, but a logical and understandable one. It's part of possibly self-medicating, a coping mechanism to get through the trauma. And that obviously also then can develop into a full-blown addiction, okay, which you're much more familiar with. I'd see a lot of commonalities between the two fields of violence, domestic violence, and chemical dependency or substance abuse field. Both are epidemic among Native people, if not the entire country, actually. Just as the Department of Justice has, back in the early, around 2001, 2002, put out a report, probably the first of its kind that specifically looked at the different ethnicities other than white, black, and then the other. And they broke it down into like Asian, Pacific, Latino, and Native women. Native women in this country are the most stalked, raped, battered, and murdered in the United States. Interesting and important note is that most of the time the offenders are non-natives. Usually violence stays within its core group. So we'll talk about that maybe in a little bit, why that is. And the stats of substance abuse within Native communities. And just as a footnote, I think it's important to note, Native communities have some of the highest levels of people who are totally abstinent as well. And I think that's a strength that doesn't get utilized nearly enough. Both violence and substance abuse obviously impact individuals, families, and entire communities. Neither of them happen in total isolation, and both are potentially lethal. I like to talk about root causes because if we don't understand the root cause of whatever is occurring, whether it's a medical illness, battering, or substance abuse or dependence, then our chances of coming up with appropriate responses can be diminished. In Indian country, colonization, the continuing tactics of colonization and internalized oppression both result or root causes, in our view, for the violence and chemical dependency or substance abuse within Native communities. Both have very strong culturally based solutions available. In other words, reclaiming our basic cultural values, lifeways, and belief systems increase our chances for nonviolent, healthy communities, relationships, and individuals. And I think important to note too is that the chemical dependency field, the alcoholism field, was started basically by people who were in recovery themselves, and that grassroots expertise through their own experience is a real strong foundation for the alcohol and drug fields, but also the same is true if you look back to the movement to end violence against women. So I've got to remember to click the dot there. Okay. So as I said, grassroots, or excuse me, looking at root causes of both can help us come up with more effective, powerful, and consistent solutions for both. And this graphic, I'm hoping you can read it, was developed by a man named Wayne Weston. He's a Oglala Lakota, worked at Sacred Circle, which is a National Resource Center at one time. So I'd like to give him credit. But on the top there where you see the red circle, it says the natural world, that's representative of traditional belief systems. And on the outer part where you see chemical warfare, femicide, and whatnot, those are basic tactics of colonization that brought to bear pressure on that sacred circle. And you'll notice, again, chemical warfare is on there, and that includes everything from smallpox blankets to the purposeful use of alcohol in terms of colonization, whatnot. But all those tactics, the pressure that brought to bear basically broke that circle, that sacred circle in a lot of ways. And that circle represents the natural belief system. We don't have a lot of time to go into that now, but it's about cooperation and respect and understanding how we're connected, all those basic values that we have as a Native people. What colonization did was impose an unnatural belief system, an unnatural world, which is represented by the triangle, which is not a teepee, it's flat, it's one-dimensional. And as an outgrowth of that belief system, then you have all the various forms of violence, loss of culture, language, and whatnot. So I know I'm speeding through this, but I think that it's really important to me to look at the impact those different belief systems have on relationships. Whereas traditionally we see ourselves as connected to all living things, everything in creation. Within that unnatural belief system, the hierarchy, many things in creation don't have spirits and we're not seen as connected. I often talk about, why we have the use of titles and, what's that impact on our relationships and how we relate to each other. To think about that, even when it comes to working with people, or trying to deal with anger or something like that, to ask them to think about how they're calling that person they're angry at. It's not by their name, it's not by how they're related. It's usually some fairly derogatory language. And if you want to if you focus on connections rather than disconnecting, you have a better chance of dealing with the violence and also developing healthy relationships. Ed mentioned this as well, that the issues of power and control, and I've also added loss to this, where oppression, violence, substance abuse are all intertwined, is about the belief system and how we even define words like power and control. And trying to, oppression is obviously about taking power and control from others, seeing themselves as superior and whatnot. But when we talk about domestic violence and in particular battering, there's a sense of entitlement, there's a sense of ownership, and it's about maintaining power and control over others. The statistics are depressing in so many ways, but I think the blessing of being Native is that we know pre-colonization, when we were living according to the values and beliefs of the natural belief system, it was extremely rare to have violence against women and children, or things that we are having to deal with today, incest through the different ways people hurting themselves and each other. It was very rare. So I think it's important to point out, because I've worked with women who, living in the world, watching the movies, listening to like rap and whatever, watching the violence that's happened within their own homes and in other people's homes, have actually come to believe that men are born violent, and that's just the way it is. It's a harsh reality kind of thing, and we need to let people know that that's not the case. No one's born, men are not born violent, women aren't born to be victimized, that we have in our histories and our cultures ways of being healthy, respectful, and peaceful, and we need to consider that and look at that and have that as the basis for hope and how we're going to overcome these and get healthy again as individuals, families, and communities, to have that vision again based on our own histories, regardless of tribe. This graphic, the trees grow from the roots up, and as I was talking about root causes, this is a graphic to help explain that. Trees grow from the roots up, so you start at the bottom. One side's the unnatural life way, and the other is the nonviolent natural life way. So if you can read the bottom there, and consider that, if those are the values and beliefs of either individuals or society as a whole, then you move up to the trunk, which are the contributors. In Indian country, that'd be like boarding schools, or really significant. And then the outgrowth is in the branches. That's the results. And too often we kind of start in the branches, and without considering the belief systems, which is the motivator for the behaviors you see on the top of the tree. On a natural life way, if you truly understand in your heart that all things have spirit, that we truly are related, that what we do matters, it impacts not just us, but everyone around us, you behave differently. The contributors to the nonviolent life way are our traditional ways of prayer, ceremony, things like that, seeking the wisdom of elders and women in particular. And then you can see the outgrowth there. So we could spend hours just considering that. Need to move a little faster. As it says here, oppression, historical trauma, and violence can cause extreme pain and fear. And that when I say that, I generally think of those cowboy and Indian movies where they use alcohol to take out bows and bullets or arrows and bullets and stuff like that. It's kind of cliche, but the truth is that alcohol and other drugs are painkillers, not just physically, but obviously mentally and emotionally as well. So there's some logic to why especially in Indian country, our rates of abuse are so high, both physical and chemical or substance. Important to note the interconnection here. There's been a number of studies done of people in treatment, both men and women, and the rates of victimization ranged from 80 to 100%. Okay. Most painful experiences individuals can go through, resulting in chemical dependency. Some of you may be familiar with the term historical trauma, and that as Native people, we collectively, through the last hundreds of years, have experienced, as it says here, a cataclysmic history of genocide, the process of colonization and all of that. It impacts us. Some people talk about it's almost like in our DNA now. And that's a consideration when working with Native people in healing. If we're healing physically, mentally, emotionally, and spiritually, then to also try to make that part of the larger picture that gets addressed. The thing I don't like about the term historical trauma is that historical makes it sound like there was an end point, that it's over. And I think the fact that Native women are so victimized, again, mostly by non-Native, is one of the indications that, colonization continues, racism and oppression continues on all levels. And that's certainly, as an advocate, part of our work. But again, I think to find ways to address that in treatment could be helpful as well. So essentially, we're talking about a lot of layers of trauma. What individual people experience, and there's the list, including witnessing violence, can also cause PTSD in different forms. Then you can have co-occurring issues, as I said, PTSD, post-traumatic stress can occur from, whether it's a vet's experience, from being raped or battered, incested, those kinds of things. TBI, traumatic brain injury. Of course, that can happen, obviously, when there's physical violence, but all, and as a result of drinking or falling, those kinds of things, fights that occur. Poverty is a huge issue, especially if we're talking about both victimization and chemical dependency or substance abuse in terms of power and control and those kinds of things. If you're poor, then it's very difficult to exercise power and control over your life. So it can be an ongoing issue. There could be pre-existing mental health issues, different types of disabilities that also complicate people's ability to be safe and healthy. And then on the larger scale, you have societal abuse and oppression. Okay, we don't have a lot of time to go into that. But in terms of battering and domestic violence, other forms of violence, as I said earlier, substance abuse increases people's vulnerability across the board for violence, in particular women, using a way for that basically people get targeted because they're seen as vulnerable, and also for increases their chances of being re-victimized. There's a huge issue about decreased access to services and safety when women are using and they've been battered. There are actually shelters that don't allow people in that are high at the time or using. So that's real controversial there. But in general, if you think of all the services that will close their doors and send them off to the treatment center or wherever because they are using, rather than seeing the fact that someone who is using is asking for help at that time, and seeing it as their chances of being harmed in whatever way have increased, and trying to find solutions that keep everybody safe. Stopping self-medication without proper supports can be life-threatening, particularly if you're working with somebody who has been, say, incested for a long period of time in their lives. Their pain level and fear level is so high that they just cannot make it through the day. And that's not to say their using shouldn't be addressed, but it's about, you know, working with the different systems to make sure that that person has the supports they need, the appropriate medication. You know, that's where collaboration is extremely important. And then very often people who are using are just dismissed, you know. Then people won't look past all the behaviors that come with using. It becomes a priority rather than in a negative way, that rather than looking at, well, why would someone put themselves in that position? You know, why are they making those choices? Then they might be trying to ask for help in the best way they can. From advocates' perspective as well, substance abuse is very often seen as a survival tool. You know, it's part of self-medication. Sometimes it's a tactic of the batterer to force a woman or to use, and it then can be used as a form of blackmail. You know, I'll tell people that you're using, and hello, I'm getting a little feedback. And you know, she might lose custody of her children, that kind of thing. Might be part of self-defense. I worked with a woman once who had been sober an extremely long time, but things happened in a way she knew her husband was out drinking, and that meant he'd come back and hurt her. She's out in the country. You know, long story short, she knew she'd have to physically defend herself, and the only way she could do that was if she had a few drinks, you know, which is maybe a fairly rare occurrence, but it's something to consider. Obviously, it can be a form of suicide or just an outright cry for help as well. There are also, one of the connections between the substance abuse field and the advocacy field is that the negativity when it comes to women, especially Native women who are drinking, you know, the language, they're sluts, they're promiscuous, they're bad women, they ask for it, those kinds of things, which makes it harder for women who are using and being victimized in either case, especially if combined, to ask for help because they feel that they're going to be judged and the consequences are going to be bad for them. On the other hand, you know, still in America, drunkenness by men is generally often seen as, you know, kind of macho, real man thing to do. That's a normal male behavior. It's promoted. And still commercials on television promote that. If women are drunk when they've been battered, they call for help or ask for help at some program. Vast majority of the time, that's when victim blaming, which is a form of re-victimization, and also self-blame kick in. Again, the alcohol takes priority over whatever violence might be happening. And it's not uncommon for men who are violent, those that are batterers especially, that they actually use their drinking as a tactic. You know, I didn't mean to do it. I was drunk at the time. I didn't know what I was doing, you know, that kind of thing. And it works. The violence gets minimized. There's either no or minimal consequences rather than dealing with both issues. There even were a lot of self-reports by men who were batterers. They were and had gone through treatment for alcoholism, and they talked about how they purposely started drinking knowing they were going to batter. That was their plan, because if the cops got called or whatever, all they had to say was, you know, I was drunk at the time. I didn't know what I was doing, or I didn't mean to do it. And again, the violence would get discounted. that's a lot of power control actually in that context. And another barrier for women for seeking help that still exists today, I think it's a resource money issue for the most part, is child care and custody issues for women that want to go to treatment. You know, I've worked with women who they voluntarily went to treatment but had to ask child protection for help. You know, what they were asking for was someone to temporarily take care of her children, and 2 years later we're trying to help her get her children back because they wouldn't return custody after treatment. Okay, okay, moving a little quicker. It's really important to make distinctions between conflict abuse, violence, domestic violence, and that should be battering. Sometimes the language we use causes miscommunication, misunderstanding. I'm not going to read all these slides to you, but one of the reasons I use this, in particular, talking about conflict when I'm doing advocacy training, is that a lot of the women that we're working with, and I think a lot of people across the board in America, their lives have, you know, from childhood on up, there's so much violence that any kind of conflict at all in their minds is the same thing as, you know, violence is going to happen. And so they may retreat, or whatever their survival skills may automatically kick in. Maybe they get more submissive, or maybe they do the best defense as an offense, whatever, because they have conflict is synonymous with violence and bad things happening. Obviously, conflict can be a positive thing for us, can be a motivator. Abuse is harder to define because in America we use it in all kinds of ways. I'm not sure, you know, we talk about child abuse, and sometimes I think when you hear about what's actually happening, it's more like child battering. But abuse basically is intentional. The aim is to hurt somebody. It can be painful, obviously, and extremely unpleasant, but it doesn't necessarily stop someone from doing what they want to do. Okay, if it goes to that place, as it says, it turns to violence if the abuse escalates to a point where someone cannot, like, leave the room or do what they want to do. I put this slide in as about what abuse is not, because for a lot of women, they're socialized to believe that being submissive is part of the women's role, that we need to get approval, or otherwise, you know, we're not being good women, that kind of thing. And I put that last line in there from an experience I had doing a session for a batterers re-education group once, and to keep it brief, one man said he thought his wife should be in there listening to me talk about what emotional abuse was, because, you know, everybody had told him to express his feelings, and his wife came home from work and said she was going to go bowling with her girlfriends after dinner. He expressed his feelings about that, and she went anyway, and in his mind that was emotional abuse. He didn't do what he wanted, so clarification is important. Violence makes you fear for your life. It could be seconds, it could be minutes. It impacts us on every level. It is about taking power and control away from another. And except for self-defense, it's a crime. You know, you can do conflict resolution classes and skill building. You can do some mental health work around, you know, counseling, therapy around abuse. When it gets to violence, it needs to be seen that it becomes a law enforcement and criminal justice matter. And in our work, we often use the term domestic violence. And that term, especially for me, needs to be clarified, because people use it and mean different things, kind of like the word abuse, but you need to ask people sometimes to clarify what they mean, you know, to give examples. Domestic violence can help, or excuse me, occurs between people who are related to each other in any kind of way. So it could be, you know, brother on brother, that kind of thing. And it's extremely painful, obviously, because there's that sense of betrayal and breaking of the relationship, and that intensifies the impact of the violence. However, when we're talking about battering, it's institutionalized, it's systemic, it's a system of continuous violent tactics that overlap. And the point of it is to maintain power and control over another person. Excuse me. There are a number of different forms of violence involved in battering. The physical and sexual violence are the great enforcers, but there are other tactics that are used that are, and if you could looked at the tactics of colonization, that's battering on a societal kind of level, an individual level. They're just as powerful. It's real important here to note that where I put constant fears for one's life is very real. There are times when, not to pick on men, but where I've had men come up and say that they've been battered, and I've asked, are you scared? And one man actually said, well, hell no. I said, well, then you're not being battered. Let's see what's going on here. A couple other men over, we're talking 20 years, said, put their heads down, said, yeah. Well, then I knew that was battering that he was experiencing in some form. And although time-wise and even in the field, it's real difficult when you talk about battering to talk about the sexual violence. It's really important to know, and especially in treatment programs, that sexual violence is a continuum of violence where sex in some sort is the weapon, and obviously has impact on every level. And again, trying to make the distinction that, yeah, we need to address the mental health issues, but we need to go further in terms of putting it in context and understanding it as criminal justice issues, as well as on a higher level because of the rates of being part of human rights violations. Yeah, I'm not going as fast as I need to here. But this next slide is just a comparison to think about our language and how we describe our work worlds and how we work with people. So again, I'm not going to read this to you. But, for women who are battered, as an advocate, we see ourselves as needing to collaborate with all other fields, but also our ability to do our work and make women safe has, we work with individual women, but we also look to do as much social change as possible. In Indian country, that's about reclaiming our culture. And again, I'll point out on this one, when we're talking about codependency, very often when you're talking about women who have been battered, we see it as in the context of the way women and men are socialized. And codependency can actually be a survival skill for us. If my choice is to turn my check over to you versus getting beaten, I'm giving you my check. That's just, in that context, that's mental health. Do what you can to keep yourself safe and not get harmed anymore. And there's an expectation, I think, on advocates by other fields very often that we do therapy and that kind of thing. And we look at it as our relationships with each other as women is therapeutic, sharing our experiences, seeing what we've been through as providing expertise is very, very important. Again, I'm not going to go through each one of these, but advocates get to be everywhere in the world. It's an expectation for an advocate that you work with the different kinds of systems, law enforcement, criminal justice, political, on and on. And the world of counselors is is different from that, but the collaboration between the two is extremely important. I'm going to go through these fast because I'd like to give you some time if you have questions, but that's why I put these are slides from when I do advocacy training. So it's about promoting the integrity and respect of women as individuals and as groups, to see what women have been through as providing expertise, and that our voices need to be at the table as well. That safety and confidentiality in particular is integral to women's safety. We'll talk about that. Our priorities overall would be safety and accountability, offender accountability, and also accountability of the systems in responding to victims of violence. I think the last one, the role of the advocate is to remain accountable to the woman who has been battered, or raped, including maintaining confidentiality. And that's where CD counselors or substance abuse counselors, if you're working with women to understand that has caused conflicts in the past, where maybe part of a woman's aftercare, she's been through treatment, and aftercare is she's been told go to this women's group at this TV program, and counselor may call to check in. If the advocate has not had collaborative conversations with the treatment program, then when the advocate says, I'm sorry, we cannot admit nor deny that we're working with the woman, please leave a message, we'll see if she gets it, if she comes around and see that if she needs help contacting me, we'll make that possible. You could see that there'd be a setup for conflict. That in our role as advocate, it's about us supporting and helping that woman do what she wants to do the way she wants to do it. So if she gives us permission to speak and share information, fine. Prefer that people talk directly to women rather than through others. So this is a diagram of the dynamics of the face of battering. You'll notice on the bottom, it's about unnatural power and control. That's the basis. The outer rim is physical and sexual violence. Those are the great enforcers. And then in the middle, you have all the different tactics, all the different forms of physical violence. And I need to say, I use the word battering, but very often women who are going through it may not use that terminology. I've had, that triangle is on a poster, and I've seen women start reading it and say, oh my God, I didn't know I was being battered. And I've seen men read it who said, oh my God, I didn't know I was a batterer, because so much of the violence is normalized, it seems, just as, male's role and female's roles, or male entitlement, that kind of thing. So, in a way, that's really good news. That means with good information, accurate and appropriate information, people may change behaviors. So that's a positive part. At the top of that triangle is male privilege. None of the other tactics are in any particular order, but when we're talking about male privilege, where it is gender-based, if there were no male privilege, it's like if you did a triangle on racism, there'd be white privilege, and all forms of oppression could be put in the same kind of triangle with similar tactics, same tactics, just acted out a little differently. Without privilege, that sense of entitlement, the sense that this is, normal and natural, and people should, kind of acquiesce to what they want, the other tactics wouldn't be possible. So here's some of those examples. That men's ways is the right way, it's more valuable, those kinds of things. Making all the big decisions, expecting to be waited on, those kinds of things. And I need to say there are many men that are not violent, are respectful to women, but they still live in a society that that male privilege is prevalent, so they still kind of benefit from it. And in having conversations with men, it's kind of like they felt uncomfortable when women constantly waited on them. But then when you talk about it in this context, then they kind of understood what that was about. threats and coercion, they're extremely powerful. And again, running out of time here, but those are playing in women's heads all the time, and very often he follows through. Killing pets would be part of that, kill the puppy, meaning, and that's part of intimidation. Again, some of these overlap. The messages that could be you, there's nothing, you can't protect yourself, you can't protect anything you love either. Very powerful. Isolation, again, extremely, extremely powerful. I'm going to go through these. Minimize lies and blames. I didn't hit her. I remember one guy telling an advocate at court, well, all I did was push her, and the advocate had to remind him, well, you pushed her down 16 steps of concrete. Emotional abuse, crazy making. There's a lot of things. If you had more time, the crazy making down for, I guess I'll give you this example, because sometimes you need to know some of the most extreme stories, so that when you are visiting with women, you can say, this is what I've heard. So it's a way of telling her, I'm listening to you, I believe you, especially if he's done something, that's way out there. And in one case, a guy convinced the woman and other people that she was going nuts. She was hearing voices. She voluntarily went to the psychiatric unit, and when advocates went to get her stuff, they started hearing voices, and he had set a recorder to the thermostat in their house. So every time the furnace kicked on, it would play this recording. She thought she was hearing things. Abusing the children is major. Economic abuse, right now there's more and more talk about that because of what's happening in the NFL and whatnot, but not having access to money, having no place to go, particularly important in Indian country where there's so much poverty and lack of housing. And ritual abuse, cultural abuse, and collusion. You see this, you might call it enabling in your professional lives. Here we call it collusion. It's the thing that allows people to continue in their behaviors and make excuses for it. Women who are battered may obviously misuse or abuse alcohol and drugs as a survival skill. Addiction can result, so sometimes treatment's important. We just don't have time to go through all of this. But as I'm talking, I'll just flip through these so I can get to some of the other. There are legitimate reasons for women not to leave, even the violence, whether there's alcohol involved or not. Let me talk a little bit about. So some recommendations, trying to become familiar with trauma-informed responses, getting to know that individual, just letting, learn as much as you can about the battering and whatever, but just sit with that person and get to know who they are. I know that sounds simple. So safety is key to recovery of all sorts. Okay, and looking at alcohol treatment programs specifically, to look for people's safety, physically, mentally, emotionally, spiritually, find the time to visit with them about that. Are we talking about codependency or survival skills? Our concern is that, if family therapy assumes both people have equal power and control and nobody is scared. If there's battering happening, that assessment, those conversations need to happen ahead of time. If a woman is being battered, then she needs to be hooked up with an advocate. Forcing someone to do family programs with their spouse who's a batterer is re-victimizing and extremely dangerous for both. Also, to see confidentiality is really key, and confidentiality in terms of sharing information only on a need-to-know basis and making sure that women control the information about them. So if you looked at every aspect of your program, one of the things I consider is it would be normal and natural to expect people who work at a CD program or substance abuse program to have recovery for a certain length of time, but does the program check to see about domestic violence? What about the employee assistance program if an employee is being battered, you know, and on and on. What if you have someone in treatment who is being battered? Is there a protection order in place? Are security guards aware? What are the protocols and procedures to make sure? Because a woman in treatment who's being battered is in way more danger. Batterers get more dangerous. More women are killed while leaving or after they have left their batterer. So we need to keep that in mind. Going to treatment is dangerous for women who are battered. And just going through all the different policies the same way to assess for safety and accountability issues. Okay, sorry, talking too fast. You've got a couple minutes if there are any questions.
Yeah, thank you so much, Brenda. And yeah, just as before, if you have questions, please submit them into the Q&A pod just to the right of the slideshow. And yeah, thank you again, Brenda, for that overview. And I just wanted to mention, since Brenda did have to move fairly quickly, since we were trying to cover a lot of ground today, we're hoping to have Brenda back in our 2015 Behavioral Health for American Indian and Alaska Native webinar program for next year. So we will hopefully be able to go a little bit deeper into this topic at that time too. Okay, we have just a question about handouts. So they are available for download in the files pod. So the handouts include both of the entire slideshow from today, and so you can download that. The files pod is just on the lower left corner of the screen, but also I will attach them in the email that I send out to everyone who attended as well. Okay, we do have a question. Is there a domestic violence program you would recommend for Native American clients and their families in treatment?
Say that again. Is there a...
Sorry, is there a domestic violence program that you would recommend for Native American clients and their families in treatment? Do you know of any specific programs, I guess, is the question?
I'm not sure of the question. I guess, you know, there are some IHS run and tribally run treatment programs. Depends on the reservation. Is that answering the question?
Okay, so you're probably best for people to check with the IHS as a first step to seeing what kind of programs there are. Okay.
Right, and if you're located close to a tribe, then generally some of them have the ability to run their own. I'm in South Dakota, so there's a number of Native treatment centers.
Perfect. I don't see any other questions right now. We'll just give a little more time for people to submit questions while I'll quickly kind of go through some last minute information here, but please type in those questions while you can, and we'll get to those before we close out. So like I mentioned, we will be sending an email follow-up to everyone who attended. This will include a link to the recording of this webinar in case you want to share it with anyone who missed it. It'll also include a link to the survey in case you don't get redirected correctly, as well as the CEH request form and handouts. And then just here's a reminder of the webinars we have coming up in both of our series. So take a look at those, and yeah, thanks again to everyone who's joined us today. Looks like we do have a question. What kind of assessment can you do to screen for domestic violence?
Okay, probably would need a little more training. There are lethality assessments out there. Don't, you know, they're useful, but they're not foolproof. But I think familiarity with those tactics. Actually, I don't do they have my email address? Because I could send, if people want to ask. I could send materials that would be helpful in that.
Okay, let me put your email address up here. for everyone. I can share it with everyone here in just a moment.
You could also actually Google a woman named Patty Bland. She's done work in both fields, and there's some really good written material came out of the I believe it was the Washington State Coalition. I have some information as well, but she's one of the lead people.
Okay, so there is Brenda's email if you wanted some more information and resources for screening. Well, thank you again, Brenda, for joining us and for sharing your experience in working as an advocate with domestic violence. Yeah, we really appreciate your perspective, and yeah, thank you to all of our participants as well. I do have a quick question here. Do we have to pay for the training certificates? We do charge $15 for our CEUs or CEHs, and that is a processing fee. It helps us cover the costs of applying to NADAC for the ability to provide those CEUs. So it is $15 per session that you'd like to earn CEUs. And again, that form will be emailed out to everyone. Brenda, did you have any final thoughts you wanted to share?
No, just that there's so much information, so please email me if you'd like more, you want to have a more conversation. But there are a number of resources out there that could help.
Great, wonderful. Thank you so much. And yeah, thanks again to everyone for joining us, and hope you have a great day.
Thank you.